Hello, I am Sarah Dash, President and CEO of the Alliance for Health Policy. Welcome to this special edition recording of our COVID-19 webinar series. For listeners new to the Alliance, we are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. We launched this webinar series to provide insight into the status of the COVID-19 response and shed light on remaining gaps in the system that must be addressed to limit the severity in the United States. You can find recordings from all the webinars in the series and additional resources on our website, allhealthpolicy.org. Before we begin, the Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting our COVID-19 webinar series. Again, you can find the materials that accompany this recording on our website at allhealthpolicy.org. The Veterans Health Administration is the largest integrated health system in the country, serving more than 9 million veterans. Today, I am so pleased to be joined by Dr. Richard Stone, who is the executive in charge of the Veterans Health Administration, to discuss the VA's response to COVID-19. As executive in charge, Dr. Stone directs a healthcare system with an annual budget of approximately $87.5 billion. Prior to joining the VA, he was a vice president at Booz Allen Hamilton. Dr. Stone is retired from the U.S. Army, where he served as the Army's Deputy Surgeon General and the Deputy Commanding General of Support for U.S. Army MedCom. Dr. Stone, welcome.
Thank you so much. I appreciate being here.
Thank you. Well, let me start by asking you a little bit about the situation on the ground. What are VA health centers around the country experiencing right now?
So we began preparing for the events that we're experiencing now back in January, when the Chinese first reported that there was the potential of a new virus that had transmitted from animals to human. We went to full-time activity when the Chinese reported that there was human-to-human transmission. And what that means is that we stood up our Emergency Operations Center, which then followed within about a week all of the emergency operations centers across the United States. These are operations centers that we use to accomplish our fourth mission, which is to be the backstop for the American healthcare system in the event of earthquakes, fires, floods, and hurricanes for the most part. And unfortunately, over the last 5 years, we've been extremely busy doing that mission. Our first mission always is to care for America's veterans. Our second is to educate America's doctors and nurses as they go through training. Our third mission is to do research in war-related injuries and illnesses. And then our fourth, since 1982, is to provide care in the event that the American healthcare system cannot fulfill its responsibilities to the citizens of America. Today on the ground, we are active in fulfilling our fourth mission in multiple ways. We're helping distribute bulk pharmaceuticals around the nation to FEMA. We are supporting hospitals in New York City by taking very ill COVID patients. We are also doing the same in New Jersey, in Detroit, in Ann Arbor, and in Louisiana. We also are partially staffing nursing homes in the Northeast that have had trouble with loss of personnel. We have also supplied ventilators to the Indian Health Service in New Mexico that are overwhelmed by the COVID epidemic. Each day we have additional missions and discussions regarding our capacity to fulfill our first mission, which is the care of veterans, and to take on the responsibility for supporting individual healthcare systems under pressure.
Thank you so much. And can you tell me, in March, the VA released a COVID-19 response plan, and I must congratulate you. It was incredibly thorough to my eyes, but can you share some key provisions in that plan? And how are you adapting, knowing that the situation continues to change on a daily basis?
Well, we recognized very early that this pandemic was going to challenge all of us. And we felt that as a service to the American healthcare delivery systems, that a comprehensive view of how to approach healthcare in this type of environment was necessary. So that is just under 300 pages that views how we are approaching this and really outlines the 2 lines of effort in every facility that has not been completely converted to COVID therapy, that protects patients without COVID and also provides optimum care to those with the virus and tries to avoid the intermixing across the facility. We're very proud of the methods in which we began to limit visitation back in March. At first, our most vulnerable patients in our nursing homes. We operate 134 nursing homes with about 8,000 veterans that are the most frail and elderly, and we felt that there was very substantial risk to them, and therefore we began limiting visitation. We did believe that much of the American healthcare system that exists in rural areas, it was very difficult for them on their own to reach the level of expertise that we had the ability to reach, and therefore making that document public. That is actually an annex to our high consequence infection document that has existed for over a decade. But I'm really quite pleased with it, and pleased that many healthcare systems have chosen to use it as a methodology to approach this pandemic.
Thanks. And if you could just take a step back, talk a little bit more about just the population that you're serving. You mentioned rural, you mentioned nursing homes. Obviously, we have a lot of frail and older veterans as well as younger ones. How are you thinking about your response as it relates to just the needs of the veteran population?
So that's actually just a terrific question because it's different in every community. In large cities with large amounts of comorbidities and a very elderly population, we're seeing a very aggressive disease with large amounts of admission to ICUs and as well as large amounts of ventilator use. The Chinese had reported their experience was that about 20% of patients infected with the virus would be sick enough to need hospitalization. We are seeing just over that, and that is appropriate across the nation. But what they also said was that only about 5% of patients would need to go to the ICU. And we are seeing in large cities, 10 to 12% of the patients needing to go to the ICU, and about 50% of those going on ventilators. The Chinese had also said that if they went on ventilators, they would be back out of the ICU within 7 days. And we are seeing ICU stays of in the 11 to 12-day range. We are seeing a dramatically different picture in wealthier small cities. In those wealthier small cities where the population has less comorbidities, we're seeing a higher incidence of admission to med-surg units and so acute medical care units, and less utilization of ICU and less ventilator use. In rural populations, it is very difficult to get a handle on, and we've been reaching out proactively across the nation to talk to public health officials and express our willingness to support them. As you are well aware, and your listeners are well aware, small rural access hospitals have been under very substantial pressure over the last number of years, and their ability to capitalize themselves as well as prepare for this type of event is very difficult. And therefore, our ability to reach out to those communities, to provide support, to express our willingness to accept patients or even support them using telemedicine is one that is just unique to this system. You know, we are the largest provider of telemedicine services in the nation, and our tele-ICU services extend across our delivery system, and our ability to deliver a intensivist on a virtual basis to the bedside in support of a nurse in a rural hospital has been used by both the Indian Health Service as well as was offered to the Javits Center in New York as they began to establish that center.
And can you paint a little bit more of a picture for us? What does a tele-ICU look like, just from the ground? How does that actually work?
For our facilities, there's robust technology that literally allows a intensivist to sit at a desk in Minneapolis and see a hospital in New Orleans, and to watch the monitors, to see the patient using various cameras, and then to work alongside the nurse on the ground to provide the intensivist guidance and care and the ventilator management that is necessary. In other situations, it could be simply a handheld telephone call in which the intensivist makes themselves available, listens to the problems in a typical telephone call. But sort of in between that, from the very robust platforms that we have in our hospitals, or we cover some of the Air Force hospitals with our intensivists, we can even work off of an iPad, which would allow the intensivist to actually see what was going on and to observe the monitors. Our idea is to be as creative and innovative as possible in this and expand this as rapidly as possible to as much of the nation as we can.
Thank you so much. And I want to ask you about a little bit more of that workforce question. You mentioned your intensivist. You mentioned the second mission of educating the workforce. As I understand it, the protocols for using ventilators for managing this, the ramifications of this disease can be complicated. Are you seeing the need to ramp up the specific training in terms of the care of these patients? How are your facilities handling that, and the central VA organization handling that?
So we have been running intensive care academies across the nation. Probably the best example of that is in Florida. Florida is a very robust system, but a very at-risk population because of the amount of elderly veterans present. As we began to take down our ambulatory care network, and we're like all other healthcare systems, over the last 20 years, we have primarily become an ambulatory care system supported by 125 hospitals that have beds in various levels of complexity, but responding to the pressures on all of American healthcare to do more things outpatient and less things with prolonged inpatient care. And therefore, we began back in February reversing that and literally training many of our primary care physicians in things like ventilator management, and training our nursing staff from the operating rooms and acute care to perform ICU services. We do believe that across the nation, for the most part, in most communities, the civilian healthcare system will well be able to handle the number of cases in med-surg acute care nursing units. Where we think that there will be pressure across the entire nation is in intensive care. And therefore, we began this up-training and cross-training of our physicians and nurses. We've also begun pulling our CRNAs out of the operating rooms that are not doing elective cases because they have the expertise to run the anesthesia ventilators, that when we're short of ventilators in an ICU, they can run those and have the expertise to do so. They have been an extraordinary asset throughout this because of their high level of competence and their ability to handle patients with compromised vital signs.
Thank you. And let me just ask one other follow-up. Are folks in the civilian healthcare system, are they able to access those trainings or take advantage of them? Or how are you working with health systems across the country to help enhance their capacity in that regard?
We have not had requests to export that training, but would be more than happy to do so. We believe that this backstop concept that the Secretary has talked about that allows communities to get to their final end game. You know, when I say that, America has well over 6,000 hospitals with 1 million hospital beds. Our 16,000 hospital beds in 175 sites is not going to replace that commercial healthcare system, but we can create a bridge for those communities that feel that they need 1,000 beds or 2,000 beds and handle the most complex patients. The other thing that we worry about is that the temporary hospitals are filled with volunteers or active component military. For the most part, those temporary hospitals do not have medical information systems that allow the recording of complex care. And we believe that the sickest of these patients, after up to 2 weeks in the ICU, will need extensive rehabilitation and pulmonary rehabilitation. And therefore, we believe that the VA is perfectly situated to take patients with those needs, to make sure that when the temporary hospitals begin to atrophy, that there is continuity in the care of patients that need our services that might exceed the capability of the American healthcare system or the temporary hospitals that have been established.
So you're talking about taking on some additional post-acute care capacity for the rest of the healthcare system that may not be able to handle it. Is that correct?
It is, but obviously this will all be at the request of the healthcare systems that then articulate that through FEMA as they recover from this pandemic.
Great, thank you. So I do want to ask you a little bit about just coordination. You mentioned, the Air Force. Can you just talk a little bit about the roles of the Veterans Health Administration and the Department of Defense, and how would you distinguish their roles in addressing the medical needs during this emergency?
Well, since most of us here grew up in the Department of Defense for the first half of our careers, it feels very comfortable and our relationships are excellent. We have, prior to this, over 165 sharing agreements with the Department of Defense across our system. So the relationship is close, it's active, and it's collegial. We do recognize the fact that the Department of Defense has been called upon to get both of their hospital ships out quickly, as well as the 1,000 beds that were established in Javits Center, as well as multiple combat or field hospitals that have been taken out, that have actually taken some of their capability away from their fixed facilities. The VA, as it's reconfigured itself, has grown over 4,000 beds since January, and will grow another 6,000 beds by August of this year in order to make sure that we can fulfill whatever contingency is needed. But the other excellent thing is we're in the early stages of establishing a common electronic medical record between the Department of Defense and the VA. As we do that, it also makes it very easy for us to move patients throughout these systems without difficulty. Earlier in the pandemic, we moved patients out of New Orleans to make New Orleans an all-COVID hospital. And as we moved patients to Biloxi, our VA hospital in Biloxi, or up to Jacksonville, it was very easy because we're on a common electronic medical record. So we believe that although we're early in this stage, the ability to have health information exchanges, which have begun to come online, have been incredibly important to our ability to operate as a common federal delivery system, whether it's VA or Department of Defense.
Thank you so much for bringing that up around the common electronic medical record. And certainly it seems like information exchange and technology is an important component of this response. I want to go back a little bit to telemedicine, because you mentioned that you're the largest provider of telemedicine, and you talked a little bit about how telemedicine is being used for the acute needs of patients. Can you share a little bit about how you might be using telemedicine for those veterans who maybe do not have COVID-19, but who have other needs, and mental health being one of them? And you mentioned your two tracks in your plan for the non-COVID and then the COVID patients. So how are you using and accelerating the use of telemedicine in that regard?
As you know, one of the most important things that we deliver is an integrated mental health system. We found that about a month before the pandemic really began to take off, our mental health patients began canceling their appointments. And we became very concerned about that in the continuity of care. We began first telephonically reaching out to our mental health community, and all of our mental health teams were placed on with the following direction, and that was they were to reach out to every veteran that was canceling an appointment or that they felt was not being seen and was at some risk. I'm really pleased. Yesterday we took a look at the statistics between telehealth and video telehealth. We are now, and our inpatient, our in-person visits that are still occurring, we're now doing more mental health visits each day than we were before the pandemic. And it's an effort to make sure that we're fulfilling our mission of taking care of this at-risk population, that the stressors that come from community isolation, which we think creates such danger in our veterans that already have problems with isolation, is absolutely essential. So I'm really pleased at the effort that's been ongoing. I'm pleased at the fact that we have such a robust mail order pharmacy system that can fulfill this, and the integrated teams of our mental health providers, as well as our specially certified mental health pharmacists have done a great job in medication management as we've gone through this, and been able to deliver the medications and the therapy that's necessary to maintain this population.
Great, thank you. And I didn't get a chance to ask you about the supply chain, but do you have a brief moment to kind of share what steps you might be taking as far as the supply chain is concerned, and is there a special role for the VA there?
Well, so because of our fourth mission, we keep not only our acute PAR levels, our usage levels, which is normally 2 weeks supply of PPE and medications. We began back the end of January, increasing that to a 30-day PAR level. In addition to that, we keep contingency stocks for our fourth mission for hurricane season and things like that is about equal to our PAR levels. And so we had been up to a 40-day to 60-day supply. We offered to act for FEMA as regional supply depots for the Strategic National Stockpile. They have a pretty robust and well-developed system and did not need our support for that, but we're appreciative of us leaning forward in that offer. We are, however, really subject to buying things around the world the same way as everybody else in healthcare is. And for just full transparency, we have worked really hard to cross-level the areas under extreme pressure like New Orleans, Detroit, and New York with those like the upper Midwest that are not seeing much COVID, and therefore we've moved masks and face shields and even ventilators around the system as only a large integrated system can. I'm quite pleased that as of today, there are no sites that have run out of any of our PPE, although I will tell you that we're not at the depth of reserves that I would like to have. and we're hopeful for the America's medical supply chain to begin to recognize the benefits of the Defense Production Act and come back to the robustness that we experienced before this started.
Thank you. We are almost out of time. I want to ask you just in closing, just a couple of questions. Number one, I think everyone in America shares the gratitude for our veterans for their service to our country. So is there anything that regular Americans can do to support the veterans community in this time? And then secondly, if you could answer, as the head of one of the largest health systems in the U.S., what advice do you have for other healthcare leaders as they're navigating this crisis?
So first, what this country needs to do is really come together as communities. And therefore, with the imposed isolation on all of us, I think picking up the phone and calling a veteran would be a great thing. And if you know a veteran and haven't talked to them for a while, pick up the phone and call them, because the country as a whole needs to come together and take care of each other. And as melancholy as that might sound, I would say to you that that's probably the most important thing your listeners could do to help an individual veteran or all veterans in this nation. I think the second issue, as a leader of one of the largest healthcare systems, or the largest healthcare system in the nation, my advice to other leaders is that although we seem to have a glimmer of hope in the bending of the curves for this disease, we believe that this will continue to percolate through America as we go through the next number of months. And whatever time we have that this becomes a seasonal virus, if we're that fortunate, we need to prepare for the next wave. And as we prepare for the next wave, it means continuing to do the things that you and I have talked about: training our force, hiring as many people as we possibly can, making sure our supply chain is stable, making sure we bring our supply chain back on shore, and then to be hopeful that the research community can deliver us a vaccine and adequate therapeutic medications that will allow us to defeat this virus. Thank you so much.
Thank you so much, Dr. Stone, for joining us. We are grateful, and we are appreciative. Now, as a reminder to our listeners, you can find additional information and resources on our website, allhealthpolicy.org. Again, Dr. Stone, we thank you and wish you a blessed day.
Thank you.
Goodbye.